Diabetes is a disease that has a lot of potential complications. So, complications are directly related to the duration and extent of abnormal blood glucose levels. So, the more often your glucose is out of range, the more likely you are to have complications. So, there are dogs that are trained, they're service dogs that are trained to detect abnormal glucose levels. And usually, people that have them are type 1 diabetics. And I know someone that has a diabetic medical alert dog. I mean, the dog's not diabetic, she is. And the dog's her medical alert dog. So, what the dog is trained to do, and I don't know how you would train a dog to do this, but I think it's really awesome. When the dog detects an abnormal blood glucose level, they indicate to the owner. And then she says high or low, and the dog does one thing for high and one thing for low. Isn't that interesting? I just think that's amazing. And she's a really neat dog. Um, and so there are service dogs that can do all sorts of wonderful things. And so if you have a dog that can detect when your blood glucose is abnormal, then you can manage your diabetes better. Now with implanted insulin pumps, that is another thing that closely manages your blood glucose level. So that, and then adjusts the insulin as needed. So a lot of factors can lead to fluctuations in your serum glucose levels. Variations in your diet and use of alcohol, changing physical activity, infection, vomiting, because that changes your chemical makeup. Complications can be acute or chronic. So the physical activity thing, that's pretty important for what we do, since we do exercise a lot with people. When I used to work in a skilled nursing facility, a lot of times the nurses would be taking people's blood glucose levels right before a meal, so they'd know if they had to give them insulin or not. And if we took someone to the dining room right after their PT session when they were exercising, their blood glucose levels would always be better. And a lot of times they wouldn't need insulin because they had the exercise. So I think that's pretty cool. And I have had people that I've been working with who were doing regular exercise with us in PT say that they were having an easier time managing their glucose levels. And I think that's great. So exercise is such a great intervention for so many things, and diabetes is one of those things. So acute complications of diabetes, there are like two, you can think of two ends of the spectrum. Hypoglycemia, which is insulin shock, too little glucose, and ketoacidosis, which is diabetic coma, which is too much glucose. So we'll talk about each one. So hypoglycemia is insulin shock is another name for it. It's more common with insulin replacement treatment, but it can occur because of excess oral hypoglycemic drugs as well. So you get excess insulin in circulation and you get a glucose deficit in the blood. It can be life-threatening or cause brain damage if untreated. It often follows strenuous exercise, a dosage error, vomiting, or skipping a meal after taking insulin. The signs of hypoglycemic shock or insulin shock are disorientation and a change in behavior. The person may appear impaired. Anxiety or decreased responsiveness, a decreasing level of consciousness, decreased blood glucose level, decreased blood pressure, increased heart rate. Immediate administration of glucose is required to prevent brain damage if someone's in insulin shock. So here's my insulin shock story. From when I was an EMT, it was the olden days. We did things different in the olden days. But I worked in a small hospital in a small city that was surrounded by rural areas. So a lot of times, unlike a big city hospital or big hospital, a lot of times the hospital emergency rooms will coordinate with law enforcement, and they do in big cities too, but to do things that like draw blood and things like that. So this was in the early 80s in Colorado, and the highway patrol would bring someone into the emergency room to get a blood alcohol level drawn if they were arrested for a suspected DUI. And there was a state lab that used to analyze and I don't know if this is still the case. I haven't lived in Colorado in a long time, but there was a state lab that would do all the legal blood alcohol levels. So the highway patrol pulled someone over and arrested them basically for suspected DUI. They brought him into the emergency room to get a legal blood alcohol drawn. And so they would do a standard workup on him, bring him in. And the patient did appear very impaired. He appeared very drunk. So you know what a person looks like when they're drunk, kind of stumbling and decreased responsiveness, decreased level of consciousness, disorientation, change in behavior, impaired, like uncoordinated, difficult to do things. And so basically, the highway patrol was going to get the legal blood alcohol drawn, and then they were going to take him, and he was going to spend the night in jail. Okay, because they suspected he was drunk driving, and he had like run his car off the road or something. So when the legal blood alcohol was being drawn, the doctor who was in charge in the emergency room, in charge of that patient, also said, well, let's draw a set of labs while we're doing the blood draw. So the legal blood alcohol, it goes out and it gets analyzed by the state lab, so we don't see the results of it. But the doctor also did a chemistry panel, which includes glucose, did a complete blood count, and did a medical blood alcohol, which we would get the results from right away. So the one that came back first was the medical blood alcohol, and it came back as 0. And so the doctor called up the lab and said, run that again. This came out as 0. That can't be right. In the meantime, while they were running again, the other labs came back and the glucose level came out very, very low. This guy was in hypoglycemic insulin shock. And the doctor's like, oh my gosh. And they administered IV glucose right away, and he woke up. He was disoriented and decreased responsiveness and everything. And as soon as they got the glucose in the blood, boom, he was normal again. And he hadn't been drinking. What had happened is he had taken his insulin. He was late for his meal because he was in a meeting that ran long. And so he was in hypoglycemic shock, and he ran his car off the road. If the highway patrol hadn't taken him in to get that legal blood alcohol, and if the doctor hadn't run the labs just to be safe, he could have died overnight in jail from insulin shock. So thank goodness that all that happened. And the other thing is, he didn't have a medic alert bracelet that said he was diabetic. So in the emergency room where I worked, we did have medic alert bracelets that we would give people, and the doctor gave him a medic alert bracelet and expressed to him the importance of, taking care of wearing the medic alert bracelet, so they would know. Because if he had had a medic alert bracelet, we would have known that he was diabetic, and it could have happened faster. So luckily, because everything worked out right, he avoided a serious problem up to and including death. So but when you see someone impaired, don't assume that they've been drinking, because it could be something like this. You never know. And when we all saw him, everybody who saw him, we just thought, yep, that guy's drunk. That's what he looked like. That's what he presented like. So never assume, never assume anything. The other side of the spectrum is too much glucose at diabetic ketoacidosis. It generally occurs in insulin dependent. It's more commonly seen with type 1 diabetics than type 2 diabetics. It's it results from insufficient insulin in the blood, high blood glucose levels, and the mobilization and use of lipids to meet cellular needs that results in the production of keto acids. So it might be initiated by infection or stress as well. It might result from an error in insulin dosage. It might result from infection, change in diet, alcohol intake, or excessive exercise. So the signs and symptoms of diabetic ketoacidosis are dehydration, so thirst, dry, rough oral mucosa, warm, dry skin, rapid, deep respiration, and acetone breath, they call it. So their breath smells like nail polish remover. Lethargy and decreased responsiveness. Metabolic acidosis, in the case of diabetic ketoacidosis, may lead to loss of consciousness. You might see electrolyte imbalances, abdominal cramps, nausea, vomiting, and lethargy and weakness. So the main difference, so that lethargy, decreased responsiveness, you see that in insulin shock, and you see it in diabetic ketoacidosis. So the rapid, deep respiration and the acetone breath and the dry, warm skin are kind of the main differences in the symptoms that you'll see between the two. Also, the abdominal cramps and nausea and vomiting from the electrolyte imbalances. So when you see someone, you might not know which one they're in. So you have to look carefully at symptoms and signs to make sure you know. Because if you had someone who was in diabetic ketoacidosis and you thought they were in insulin shock and you gave them glucose, you're going to increase the problem. You're going to increase their glucose even more. So it's good to know. A lot of clinics and doctor's offices and PT clinics have diabetic emergency kits where they have concentrated forms of glucose. And most diabetics are very aware of what to look for. Not all of them are, though. So it is something, people with diabetes have different levels of how they're taking care of themselves. Most people with type 1 diabetes that I've ever met are on it because they've been on it since childhood. People with type 2 diabetes, there's more of a range. Some people think that they can just eat whatever they want and control it with insulin. Some people don't like doing like a finger stick or anything like that, so they don't monitor their blood glucose levels very often, and that can cause problems. So everybody's a little bit different on how they manage it. So these acute complications are very serious medical emergencies. Chronic complications, on the other hand, are long-term, but still very serious, but you're not going to have the acute problems. So vascular problems, there's an increased incidence of atherosclerosis of people with diabetes, changes occurring in small and large arteries. We were talking about congestive heart failure and how people with diabetes mellitus tend to have like a more restrictive heart failure because their heart is stiffer, it's not as flexible, and that's because of these vascular problems. Microangiopathy, which is changes in microcirculation, obstruction or rupture of small capillaries and arteries. So you get tissue necrosis and loss of function. You get neuropathy and loss of sensation. Retinopathy it's the leading cause of blindness, and chronic renal failure. And that's caused by degeneration of the glomeruli of the kidney. So lots of huge problems that can result as a chronic complication of diabetes. So we had the microangiopathy, which is resulting in small tissue necroses. Macroangiopathy affects large arteries, and it can be the result of abnormal lipid levels, and it increases your incidence of heart attacks, strokes, and peripheral vascular disease. It may result in ulcers on the feet and legs that are slow healing because of that macroangiopathy. And it is one of the most common reasons for amputation, unfortunately. Peripheral neuropathy is a common complication caused by ischemia in the microcirculation to the peripheral nerves. You get impaired sensation, numbness, tingling, weakness, and muscle wasting. The neuropathy that happens with diabetes tends to have what they call a sock and glove presentation. So imagine socks and gloves. That's where the numbness and tingling and weakness start to happen, in the feet and the hands, where your socks and gloves would be. Other chronic complications include infections. They're common and often more severe in diabetics because bacteria love sugar and you've got more of it in your blood if you have diabetes. Infection in feet and legs are caused by vascular and neurological impairment. Fungal infections are common, caused by candida in the vagina or the oral cavity. Urinary tract infections are common. Dental caries, so cavities, gingivitis and periodontitis are also common. So lots of potential chronic complications with diabetes. Cataracts, you get more, the lens of the eye becomes more opaque, and that is related to the abnormal metabolism of glucose. When someone who has diabetes is pregnant, complications can occur for both the mother and the fetus. There's an increased incidence of miscarriage with diabetes, and infants born to diabetic mothers may have an increased size and weight for the date, and they may experience hypoglycemia in the first hours after birth. So that's something that they're really aware of when a mother has diabetes. There is such a thing as gestational diabetes, where someone develops diabetes just while they're pregnant, and it usually resolves after they have the baby. So exercise recommendations are going to be different for type 1 versus type 2 diabetes. And these recommendations are not in the textbook. They're from the American Diabetes Association. So regardless of the type of diabetes, regular physical activity is important for overall health and wellness. And I'll just say, regardless of anything, regular physical activity is important for overall health and wellness. But with type 1, it's really important to balance insulin doses with food intake and activity, even when performing your activities of daily living. So that's still activity, that's still using glucose in your cells. And so you have to balance everything, your insulin, your food, and your activity. People with type 1 diabetes need to plan ahead and know their typical glucose response to exercise so they can keep their blood glucose from going too low or too high. And most people with type 1 diabetes, like I said earlier, most people are diagnosed in childhood or adolescence. And so by the time they're adults, they know how to manage their blood sugar. But most people know that they need to plan ahead, and they need to know what to eat, when to eat it, and what type of exercise to do so they can keep their blood glucose from going too low or too high. Because too low, you could end up in insulin shock. Too high, you could end up in diabetic ketoacidosis. So exercise, of course, affects glucose metabolism. And so all of that plays in food intake, activity level, and insulin doses. So for type 2 diabetes, the American Diabetes Association recommends both aerobic and strength training. So aerobic exercise helps the body use insulin better. It also strengthens your heart and bones. It relieves stress. It improves blood circulation, reduces the risk of heart disease, lowers blood glucose and blood pressure, and improves cholesterol levels. So yay, aerobic exercise. The American Diabetes Association recommends 30 minutes of moderate to vigorous intensity aerobic exercise at least 5 days a week, or a total of 150 minutes per week. And that is something that we often are going to help our patients with, is exercise prescription. Strength training, also called resistance training, makes the body more sensitive to insulin and can lower blood glucose. So one of the problems with type 2 diabetes is decreased insulin sensitivity, or increased insulin resistance. And so if your body is more sensitive to insulin, it can actually lower your blood glucose because the insulin is escorting the glucose into the cells. Strength training also helps maintain and build strong muscles and bones, reducing the risk for osteoporosis and bone fractures. People with diabetes don't heal as well because of the microangiopathy. And so if you can stay strong and not get hurt, that's even better. The American Diabetes Association recommends doing some type of strength training at least 2 times per week, in addition to aerobic activity 5 days a week. So this is an achievable goal, and we can help people do it. So for physical therapy, we want to work with them on their glycemic control. So if they have new illnesses like an infection, a systemic illness, the new processes to fight the illness require added glucose metabolism. So it's important for the therapist to monitor the patient's blood glucose levels during therapeutic interventions, because the symptoms of diabetes might be exacerbated in a patient with significant comorbidities. So if you're working in an acute care setting or an inpatient setting, you have the team helping you monitor this person's blood glucose levels. If you're working in outpatient, you don't necessarily have the team working with you, the nursing staff and that sort of thing. But if you know someone's diabetic, you can talk with them about how they're managing their glucose levels during exercise. So that's really important. So if somebody, sometimes I'll have a patient come in and they'll say, wow, I'm really having trouble controlling my glucose levels today. They might have like an oncoming infection that they don't know about yet. So sometimes that can be a reason to hold exercise for that day. So really people with diabetes present with a wide range of individual normal values. So establishing the tolerable high or low value for each patient during the initial evaluation is important in determining the parameters for physical therapy. And so that's something that the PT is going to do in the initial evaluation. Patients with poor glycemic control can have wide fluctuations in their blood sugar levels daily. So always be sure to verify their blood sugar level before physical therapy. And most outpatients will do this on their own. Like they test right before they come in, or if they have an insulin pump, they can just look at their monitor and see it. A pre-exercise glucose level less than 100 milligrams per deciliter might need additional carbohydrate adjustment before starting the activity. If the patient feels well and they're not in ketosis, then monitored exercise can proceed. Patients who were following a regular exercise program for glycemic control before they got admitted to the hospital need to be educated how to modify their exercise during their hospitalization and on discharge. So it's going to depend on what their current illnesses are and why they're in the hospital, but they might need to be doing a little bit less than they were doing before they were admitted to the hospital. So hypoglycemia may occur during exercise up to 24 hours after exercise because of the inability to regulate insulin levels. So to help prevent this, the patient should consume extra carbohydrates before and during exercise. And the recommendation is 10 grams of carbohydrates per 30 minutes of activity. So, I mean, that's not a huge amount, but that just keeps them at the right level. The circulation of insulin that's injected into an exercising limb is enhanced as a result of the increased blood flow and temperature of the limb. So insulin injection into an exercising limb might lead to hypoglycemia because the insulin is metabolized faster. So usually what is recommended is that they inject the insulin into the abdomen to prevent the process. So rather than doing it in your arm or leg, you do it in the abdomen, and that prevents that accelerated metabolism of insulin. The insulin is really important during exercise to modulate the glucose production from the liver and the breakdown of fats, the lipolysis. Performing exercise without adequate insulin can lead to hyperglycemia and ketogenesis. So you could get into a situation of diabetic ketoacidosis. So coordinating physical therapy sessions with meals and insulin injections can help optimize exercise tolerance. So keeping glucose sources like graham crackers or honey or peanut butter or the diabetic emergency response kit is helpful in case someone does get hypoglycemic with activity. So if you work at a clinic right now, check and see if your clinic has a diabetic emergency response kit. And if they don't, that might be a nice thing to get, to have. And sometimes we, in our clinic, we also have speech therapists, and speech therapists have food because they have to monitor swallowing and stuff. So they have to test people with different textures. And so sometimes, even if someone's not a diabetic, if they feel a little bit lightheaded and they haven't had breakfast, we'll give them graham crackers or a granola bar or something like that, just to keep them going.